Beautiful. Okay, so before we begin tonight, I'd like to advise those participating that we will be recording tonight's session. Good evening, everyone. On behalf of Eastern Melbourne Primary Health Network and Banksia Palliative Care, I wish to welcome everyone to the Conducting Essential Conversations with Palliative Patients and Their Carer webinar. My name is Sonia Mbezi, and I am the Palliative Care Program Facilitator at Eastern Melbourne Primary Health Network, having previously worked as a physiotherapist in palliative care for the last 12 years. Now, before we begin, I would like to start with an acknowledgement of country. Eastern Melbourne Primary Health Network acknowledges the Wurundjeri people and other people of the Kulin Nation, whose unceded lands our work in the community takes place. We pay our respect to Aboriginal and Torres Strait Islander cultures and to elders past and present. EMPHN is committed to the healing of country, working towards equity and health outcomes, and the ongoing journey of reconciliation. We recognise and value the knowledge and wisdom of people with lived experience, their supporters, and the practitioners who work with them, and celebrate their strength and resilience in facing the challenges associated with recovery. We acknowledge the important contribution that they make to the development and delivery of health and community services in our catchment. So just some quick housekeeping. All attendees will remain on mute throughout the conversation. We will be having an interactive session, so please put your hand up if you would like to participate. Any questions you have, you can put in the Q&A box at the bottom of the screen, and these will be answered throughout. So just a little bit about the PHNs. The Australian government established primary health networks to increase the efficiency of medical services, reduce fragmentation of care, and improve health outcomes for everyone, especially for the most vulnerable. The PHNs achieve this goal by improving access to existing services, commissioning services to improve health outcomes, and by supporting GPs and others to innovate and further improve local healthcare. We aim to improve the health for our community by ensuring people receive the right care in the right place at the right time. Tonight's event focuses on the art of conducting essential conversations with palliative patients and their dedicated carers. As healthcare providers, it's important to equip ourselves with the knowledge and skills to engage in compassionate, informed, and respectful dialogues during this sensitive phase of patient care. Now to introduce our wonderful presenters tonight. Dr. Chien is a palliative medicine specialist consultant who serves at various different hospitals and in community palliative care services in Victoria, including Banksia Palliative Care. On Saturdays, he also practices as a general practitioner. His dedication to is steadfast, focused on supporting individuals with progressive, incurable disease to improve their quality of life, despite the challenges of illness and end-of-life care. Beyond his clinical responsibilities, Chien tirelessly works to enhance community care through his clinical and administrative roles. Moreover, he actively engages in teaching and mentoring medical students and specialist trainees, fostering a culture of academic excellence and compassionate care across all clinical environments. Anna is a support and wellbeing manager at Banksia Palliative Care. With 13 years of experience as a social worker, primarily in the aged care sector, spanning hospital and community settings, Anna brings a wealth of expertise. She is deeply committed to social justice and equality, making her a valued advocate in her field. Dr. Hossein is a specialist physician in palliative medicine and serves in both the public and private hospitals. His extensive experience spans community palliative care across regional and metropolitan areas. Committed to delivering equitable care to patients with life-limiting illnesses and their families, Dr. Hossein strives to enhance accessibility to palliative services for all. He offers compassionate, personalised care tailored to individual needs and actively mentors the next generation of palliative care patients. Engaged in research to elevate patients' care standards, Dr. Hossein's dedication to improving palliative care and nurturing future professionals remains steadfast in ensuring accessibility for all in need. And finally, Crystal. Crystal is a registered nurse for over 20 years with 15 years of experience as a nurse immuniser. Her passion lies in public and community health education and communicable diseases. Throughout her career, Crystal has gained extensive experience in diverse roles from aged care, ward nursing, remote humanitarian international aid, as well as a nurse practitioner. She currently works at the HealthPathways program specialist with Eastern Melbourne Primary Health Network. Wonderful. Now that's all from me from my introduction, and now I will hand over to Dr. Hossein so that he can commence tonight's topic.
Thank you very much.
No problem. You should be able to just share over the top of mine.
Yep. Okay, I hope that you can see my slides. And hello, everyone, and thank you all for joining. Thanks, Sonia, for the introduction. Before I start, I'd like to acknowledge Banksia Palliative Care Services and Michelle Wood, Annie Lee, who has actually helped to support these services, and some of the materials that we have we are reporting are generated from different services, including Eastern Palliative Care, Eastern Melbourne Primary Health Network, Sonia, Nicole, and Meg, with the support, and Northwest Melbourne Primary Health Network, Jen Francis. There are a number of topics that we're going to cover tonight, and they're all in the context of care of patients living with life-limiting illness, including disease trajectory and care, talking about limitation of medical treatments, how we can approach to conduct an essential conversation. We'll talk about informed consents in palliative care and human rights, how we can recognize terminal phase changes, and we'll talk about, at the end, advanced care planning, and we'll talk about how to respond to patients who do request a wish to hasten death. When we talk about life-limiting illnesses, treatment limitation, and so forth, talking about death and dying is also part of the conversation. Death is an unavoidable part of the cycle of life, but despite that, many of us do everything we can to avoid accepting our mortality. But becoming to terms with death as an inevitable outcome gives us a vision and plan to live more fully in the here and now. Before we jump into our main topics, I'd like to remind about when palliative care should be considered. As you know, palliative care is targeted towards people living with a life-limiting illness, that is, people living with an active, progressive, advanced disease who have little or no prospect of cure and who are expected to die at some point from their illness. Historically, it was assumed that palliative care should commence only once all the treatments aimed at curing the person has finished. Now we know that it's well accepted that there is a benefit in providing palliative care in association with disease-modifying therapies that aims to prolong life. Also, a reminder that most illnesses follow one of the typical illness trajectories in these graphs. So on the top left side, we have short period of evidence decline, in which there is a long maintenance of good function, which may be followed by a few weeks or months of rapid decline prior to the death. And most reduction in the function occurs in the person's last few months of life. So we observe this type of pattern in patients with most malignancies. On the top right-hand side, we have long-term limitation with intermittent serious episodes where there is a gradual decline in function and it's interrupted by episodes of acute deterioration. And while there is a risk of dying during each of these acute episodes, the person might survive, but will continue to decline in the function. And that makes the timing of death uncertain, and it would be difficult to prognosticate when of these declines would be the last presentation. And some of the patients are living with end-stage COPD, end-stage heart failure, or renal failure can sit in this category. And in the bottom is a prolonged gradual decline. There is a long-term progressive disability and reduction in function. And death may follow other events such as infections. Patient might have a fall, end up having a fracture. And usually patients who are living with dementia or who are quite frail are common examples in this category. So when caring for a person with multiple severe or end-stage comorbidities or even frailty, it is essential to have a good understanding of which therapy provides benefit and which may cause more harm. And the duty of us as the healthcare providers is to mitigate suffering. And remember this quote that says, to cure sometimes, to relieve often, and to comfort always. And in addition to that, you should remember that death should be recognized as a natural culmination of life. So how do you engage with patients and families who request treatments that is not medically appropriate, or there might be some conflicts between family members? You've heard about these phrases that during your practice, who wants everything done, there must be more treatment that he can have. Should he not be in the hospital for antibiotics or IV drip? Can't we at least give subcut fluids? I might ask Chien and Anna to jump in and just give us a bit of insight. Might start with Chien. How would you actually approach these? Sometimes can be a bit difficult conversation when patients or the family approach and requesting some treatment that you might feel medically not appropriate.
Yeah, and everyone approaches this differently. And I think specifically treatment requests, we might have set this up to a degree ourselves with the modern scientific system where we have invented and be able to provide so many treatments that that we have set up additional expectations that that there must be more treatments that people should be getting towards the end, and really is that realignment of the benefit and burdens of treatments in this situation, and explaining to people in setting of incurable diseases that any temporary treatments actually do not restore any function, and that it may buy them more time, it may not, and ultimately there are treatment burdens that's very real, and if people want to go to hospitals, then they can't spend time at home. So it really is that understanding of different options and the benefits and burdens of everything, but also it is our responsibility to give an accurate assessment of whether the treatment will actually work or not, because there are some treatments like CPR being the poster boy that really is not going to have any beneficial effect at all. Whereas there are some harder, lower burden treatments like a travel or antibiotics may be quite low burden and tolerable and may still help temporarily and can be given at home. And on the other hand, setting the right expectation that perhaps if it hasn't worked after a few days, that there's no point to continue, that there's perhaps unacceptable to trial IV antibiotics if oral antibiotics has failed, because the yield is not that high if one line has already not clearly not worked. So I'll pass on to Anna.
Yeah. Oh, thank you, Chien. Might ask Anna, because sometimes families or patients might even ask allied health or even social workers about, and they may still request these questions that you might just feel like, okay, these are medical questions, but there might be a bit of like a background to that, not just as a medical question. How do you approach? How do you navigate?
I think when we're having these conversations, it's important to remember that people are often already grieving. So even if it seems like they're not accepting that the person is dying, they can see a deterioration. They can see a change in the person. They know that it is coming, even if they're not at the point of acceptance. And so sometimes these statements are made from a place of, of the fact that they're still processing that kind of grief, and not wanting to feel like they're giving up on the person if there is no further treatment. And I think I actually have an example of someone who did ask a nurse if his loved one could have a blood test done, and she was like, she was pretty much terminal. She died within that week, and he knew that she was dying. Well, he knew that she was dying, but he thought that she had longer, basically. And so he said to me, I don't understand. The nurse said that there's no point, and I don't understand that. And I think sometimes, I don't know how explicit the conversation is sometimes in terms of there's no benefit to do a blood test because we're pretty much looking at, she's terminal now. We're pretty much looking at she is dying. And to the point where actually, because it is hard to have these conversations, especially with families who aren't ready to, or seem like they're not ready to hear it. But to the point where the night that she actually did die, he was ringing the ambulance and ringing us because he wasn't sure if she was dying or if she was just in pain. And so I think the education side of it, and if we actually have these really difficult conversations early, and even if there is this pushback and all of those sorts of things, we can actually start supporting people through that kind of grief process even before the death occurs, and that can help with the grieving process once the person has died. So I think it's all about remembering that, families are probably already grieving from the point of diagnosis. And then, they have hope, there's treatment, and then there's no treatment. And it is a process for them to get their head around that and understand that, whoever that person is that's been so significant in their life is not going to be there anymore. Yeah, I don't know. I think that's it.
No, thank you. And I guess hearing that was a quite an interesting example, because it's important actually to identify, what is behind that request. That's what I'm hearing from what Chien and Anna you said, that there is something behind it, that people are asking for something. Sometimes it might just feel, they just feel like, okay, having more treatment might mean that we're doing something. So have we as clinicians offered them something instead? If you're not going to actually give them the antibiotic, what are we going to provide them? So it's important to say, well, okay, this is not going to help, but I can actually deliver this, which is going to help. So they don't feel abandoned, I guess, as one of the reasons that people still want to show their love as a family member. They just don't want that guilt that they're going to live with, that, oh, okay, I could have done something stronger, so my loved one could have lived a bit longer. So people have feelings. It's quite difficult, and sometimes need a lot of time and skill to actually get to that point. And sometimes it's about actually us as clinicians, because we are generally trained to maintain health and fight illness, but typically receive little guidance on how to communicate with dying patients and their families. So in our death-aware society, it's not surprising that many physicians find it difficult even to engage with difficult discussions. And this has been regarded as equal to medical failure sometimes, which implies that physicians have nothing to offer. And we should actually recognize that quite the contrary is true. And good communication can help to reduce the fears, minimize the pain and suffering, and enable the patients and the family to experience a peaceful journey of illness and death. I guess if I go back to this illness trajectory, in the top left-hand side, you see actually people do really well for quite a while, and there's a rapid decline, and can be a big shock for them. So some people with other illnesses in the top right-hand side might have experienced some episodes that being quite unwell. They've been told before that, okay, this could be the last time, this could be the last time. So they've heard about it. But some other patients, they've been relatively well, maintained the function well, but then there's a rapid change. So that can be quite difficult to actually to cope with the new changes. So a large majority of patients are interested in discussing end-of-life care with the physicians, and most believe that it's the physician's job. They should actually introduce the topic, and clinicians should accept that this is our responsibility to initiate the timely dialogue, as many patients will wait for the physician to raise the subject. And also remember that discussions about only focusing on resuscitation fail to recognize the important physical and psychosocial concerns. Here are some topics that we should address during our essential conversation about journey mapping. I'll talk about it down the track. Treatment options, treatment limitations, prognosis, identifying the fears, some unfinished business they've got that they need to actually do. Preferred place of care, preferred place of dying. Do they have advanced care directive? Do they have a medical treatment decision maker? And you can name a few more. During our training, we're often taught to address resuscitation status with language similar to this. Just read it out. I need to ask you some questions that we ask all patients who are very sick. These questions are about CPR or cardiopulmonary resuscitation. I need to know your preferences. If your heart stops beating, do you want electric shock and chest compression? And if you stop breathing, do you want us to put a tube down your throat and attach you to a machine? As you can see, this discussion lacks a lot of components of the patient's care. It lacks empathy. So it limits the physician-patient alliance. It doesn't address prognosis. The patient doesn't know what they're going to deal with. So patient might request CPR with an unrealistic expectation, and it inappropriately emphasizes on the intervention, as I said, that you're not going to provide. It doesn't give any sort of like an ongoing care that you're going to deliver as comfort care. And finally, the burden of decision making is all pushed onto the patient and the family, and the physician is not providing any guidance in addressing these complicated issues. I found this pragmatic four-step approach to discuss essential conversation in a patient with life-limiting illness quite helpful. So it's initiate discussion, clarify the prognosis, identify end-of-life goals, and then you develop a treatment plan. So we start with discussing in a sensitive way as to create a forum for ongoing dialogue. It's not something that can happen just as a one-off conversation. And each step provides a necessary foundation for a future discussion. as the illness progresses, the hopes and fears changes. The very big example is that someone who presents with some GI bleeding to the GP and said, and they're hoping is that, okay, it's going to be something simple. It's probably a hemorrhoid or fissure. I was constipated a while back, so it's nothing. The GP get concerned, sent to for some further test. It comes back, oh, there are some lumps or bumps there. We need to do further investigation. So the hope is that, okay, I hope this is just a benign thing, nothing to worry. It comes back as malignant. Okay, I hope there's a treatment for it. So see, their hopes and fears do change. Get the treatment. Well, a few years back, comes back as a metastatic disease. Okay, there's no cure. The hope is now, okay, I hope I can live long enough with some palliative chemotherapy or immunotherapy or radiotherapy. Then the disease progresses, and then the person becomes too unwell. Time is short. The hopes and fears do change. The hope is that I hope I'm going to have a painless journey. And I hope actually that after I die, my family can actually cope. So as you see that as the illness progresses, the hopes and fears can change. And then the physician or clinician is challenged to respond to the pain and the fear of a patient and the family that are experiencing through this journey. And in this context, Emmanuel talks about fearless healing, which is to heal, one must witness pain without fear. Healers can hear pain. Healers give people permission to show pain. Healers are not afraid to see pain. This means initiating an end-of-life discussion with a terminally ill person or discussing worsening prognosis. Like this quote, I know this is a very difficult time for you and your family. You've never been this sick before, and I know that it must be frightening for you. I want you to know that as bad as it is, we will deal with it together. So it shows that actually there's a journey that the physician or clinician is going through with that patient together. And sometimes fearless healing means listening to a patient talking about the physical decline, the emotional or spiritual suffering. Even when curative therapy is no longer effective, the physician's involvement can be a powerful source of comfort. It says, well, I can't cure you. There are still many things I can do for you. I want you to be able to speak openly with me so I can help you best. No matter what happens, I can be here for you, so you're not alone. And often it's important to try to ask more probing questions. People actually come up with some phrases that might have some meaning behind it. So you said, like some examples here, you said you don't want to suffer. What type of suffering are you talking about? We probably should avoid presuming what they mean. You said that you don't want to be a burden to your family. What do you mean by that? You said that you don't want to be kept alive as a vegetable. What does that mean to you? And in here, you can also clarify patient's wishes, the preferences of a terminally ill patient towards that less aggressive care as the illness progresses. Most patients believe that at some point, life-prolonging intervention should be limited, and that's the expectation that they will actually have from the clinicians. So it's important to ask, are there any treatments that you may not want to receive? And there's a natural inclination to use ambiguous language when discussing bad news or to downplay the seriousness of a patient's condition. So when there is no therapeutic options available, the physicians must acknowledge this with directness and compassion. There must be no chance for misunderstanding. And when you're talking with patients with terminal ill conditions, and they're not fully aware of the prognosis, they tend to overestimate the survival, which influences their preferences regarding the medical treatment. And it is very important that it is a very a stressful situation when patients and family come and sit with you and you're talking about a bad news or a new news for them. So it's important to repeat and explain what you've said. So during these times of high anxiety, the concentration and comprehension may be more limited. So it's very helpful just to check the patient's understanding at times. And we hear this phrase said quite frequently to patient and family that we don't have a crystal ball. And that is true, that we don't have a crystal ball regarding the prognosis about how they're going to actually progress. But you don't need a crystal ball to estimate prognosis and discuss it. We as doctors and nurses, clinicians have enough patients with similar condition, so we can tell them where they are in the journey of the illness. And a very typical example is the pregnancy. Someone comes in pregnant. You can't just tell them, okay, I don't know what's going to happen. You can't go anywhere. They just need a bit of roadmap. Okay, this is going to be a 9-month pregnancy. Some people deliver earlier. Some people go post-term. We divide it into like a 3 trimester. So you're in the first trimester. These are the things we're going to do. These are the things we're going to do at second trimester. These are the things we will do later. These are the things you should avoid. These are the things that you should take more. And you need to watch for these things. Some people do it without any trouble. Some people might have high blood pressure or other complications. So you give them a bit of like information. You can't just leave them in dark. And it can actually be given in different sort of estimates. So that is the roadmap. People need to know, okay, you've got cancer, you've had a couple of lines of treatments. Where am I in my journey of life? So sometimes you just need to zoom out, look at a bigger picture, where they are at, and that would help you and the patient, the family to plan. And that's about actually walking 2 roads. Once you talk about the patient's realistic expectations and their hopes and often fears, you can talk about walking 2 roads, which means that you're hoping for the best outcome and simultaneously have planned for what if things do not go as we planned? What if things do not go as we expect? And it's quite actually important to make sure that people have that understanding. And then once the patient and family acknowledge that death is approaching, the physician's role is to facilitate an open discussion about desired medical care and remaining life goals. So like as a doctor, I want to make sure we are always doing the things that might help you and that we never do anything that either can't help you or you wouldn't want. So it's talking about actually focusing on the patient's preferences and wishes. So I need to know what things are most important to you. Given your illness, how do you want to spend your remaining time? And the second one talks about, a few months ago, we spoke about what kind of care you would want if you were to become very ill. We're now facing that situation. I want to know if your thoughts are the same. So it's always good to recheck where they are and what they want. People's, as I said, wishes and preferences and the fears can change and evolve. And occasionally a patient or family will say they want everything done, as I said, to prolong life, regardless of prognosis. Sometimes patients say, I don't want my children. I know my children wouldn't want me to give up. I have to keep going for them. Might again open up to Anna and Chien. Anna, how do you respond to these sort of like comments that we do hear quite often?
Yeah, I think it can be it's really a really interesting one, because when you were talking through these slides, I kept thinking often families don't give the person who is dying the space to actually talk about what they want or what they think about death, because either they don't want to talk about it themselves, or because the person who is dying doesn't want to burden them with that kind of conversation. You know, we're kind of in this society where we don't want to be negative. We always want to be positive, and we always need to think positive thoughts, and death is very taboo and seen as something that, you know, makes people sad. So I think it's really important when you are talking to people that are dying to think about who is in the room and how that may be actually impacting the conversation that you are having with them. But with something like this, you know, I know my children wouldn't want me to give up. I would say, do you think that your children would want you to continue to suffer? Like, I would spin it in a way to talk about, yes, but are you actually giving up, or are you just taking care of yourself? And would that be actually what your children want? To see you comfortable, to see you, you know, not suffering and that sort of thing. So I think, and that's the whole thing of understanding the underlying motivation, because often, you know, partners, often when I talk to people about death or dying or where they want to be when they die, a husband will say, oh, no, we're not talking about that, you know, because it's a very difficult conversation to have, but that doesn't mean that the person who is actually dying doesn't want to talk about that. So then it's about, well, you know, let's just talk about it, you know, like making it a safe kind of conversation to have, that if we talk about it, it's not going to happen sooner. It's just planning, basically. All right, Chien?
Thanks, Anna, and thanks for saying. Yeah, I think it is a challenging. I mean, I think all the questions we have in the talk are challenging, and that's why it's good to have a space to share everyone's approach. And I think we will need to go down how I approach this. I will go down to what it means for living, for them to be living, what life is to them, and also what fighting is, what giving up is. Meaning to them. And again, if we can't treat the condition, in fact, there's actually more things to do. So there's a lot more care. There's no giving up at all. There's actually more things to do for sure. So, but yeah, but really knowing what they mean by living and what they mean by fighting is one key. And yeah, that's how I take the conversation.
Thank you. I love that comment, Anna, that you said actually it needs to be in a safe, they need to actually feel the conversation that in that safe context. So they need to be heard, they need to be acknowledged, and Chien said it's about actually identifying what is upsetting them, what is the meaning of life, what it means. If they're asking for extra fluid, extra food, something that acknowledging that importance for that person and for that family is quite important. Thank you. And often patients look to their physicians for guidance. So it's the doctor's responsibility to develop that treatment plan. I talked about this earlier. The comprehensive treatment plan should include the site of care, effective pain control, the use of CPR and other aggressive treatments, and implementation of palliative care at times. So, so I've written here that from what you have said, let me suggest the following plan. Please tell me if I'm correctly representing your views. Given that being at home and spending time with your grandchildren are most important to you, that is what we will focus on. We can recognize your radiation treatments on an outpatient basis. I can also arrange to have visiting nurses see you at home as needed. Let's make sure that we design your medical care so that you can accomplish what you want with your remaining time. So in here, it just acknowledges that the patient's preferences is to be at home and trying to tailoring the care in a way that they can actually support that care at home. And again, preferences regarding resuscitation must also be clarified, as most patients wish to have some limits imposed on life-prolonging interventions. And if a patient has stated earlier their preference to forego invasive treatment, it's important to reconfirm such a decision. And again, talking about resuscitation, most people gain at least some of the knowledge about CPR from television, I guess, where the majority of resuscitation attempts are successful. So patients frequently overestimate the utility of CPR and are particularly unaware of the poor outcomes for the chronically ill conditions. And patients, so they need to know that the likelihood of survival is related directly to their underlying illness. So if you're talking about someone with a terminal stage of a chronic disease, then the CPR is rarely, if ever, going to be successful in prolonging meaningful life. And again, as an inevitable death nears, family members must understand that aggressive intervention changes only the time and condition of death, but not the patient's ultimate fate. And in these instances, foregoing aggressive resuscitation allows for a more comfortable and humane death, and it represents an act of love, not one of abandonment. Okay, now we talked about 4 steps approach to conduct essential conversation. We now have some time to cover more topics to discuss. One of the topics is informed decision in this era. You might have heard these quotes that, please don't tell my dad that he has cancer, or don't tell my mother you're from palliative care. Chien and Anna, again, how do you respond to that requests?
I might quickly go first, and I think taking a step back, not that I responded directly like this, but just reminding everyone that in a sense, if consented to care provision, we don't have to go through the diagnosis again, technically. And if they're happy for me to look after them, they don't need to know that I'm from palliative care. Saying that though, if they're refusing pain relief when they do have pain, then we do need to explore a bit more that the importance of it and why we're actually using it. And yeah, we do need to then address the diagnosis and the care service. But yes, saying that though, yeah, I think very common barriers and yes, in a setting that if they do refuse the care or the service, then yes, we do need to work a bit harder to make sure everyone's on the same page in that that they will need more care at this stage, and in exploring that often people already know, and that it's not people try not to talk about it, but often the person knows something's going on, and that I do signpost though to say, look, when we approach it, I do ask whether they want us to talk about it, or whether and one whether they prefer us to just talk to the family, which is fine as well. So and that's a lot of people's preference, especially in some cultures where the preference is actually just they trust their families to make the decisions, and that's fine as well. But yeah, and I sometimes actually say, you're happy for me to talk about it, but do you want me to talk about it if it's not good news? And yes, I've had people who said, okay, maybe not. but they're happy for us to continue caring for them, basically.
I think just going off what you were saying, I think it's different if the person is aware of their prognosis or diagnosis or whatever, and says to you, I actually don't want to know anymore, chat to my family. I think when I always find this very interesting kind of issue, because whilst I do understand that in some cultures, and we have to respect everybody's culture, and that in some cultures it's not done. Everything is done through the family, and that's, you know, that needs to be respected. I do think though that, again, it's important to explore, why don't you want me to tell your dad that he has cancer? Like, what do you think? And not so blatantly and rudely, but, you know, tell me why, you know, you wouldn't want your dad to know this, or, you know, why don't you want your mum to know what service we're from, and those sorts of things. Because one comment that I had once was, if they know that it's cancer, it's going to kill them, which is a really interesting, and not obviously, but they did mean psychologically that it would make them down, and then they would give up on life and all of that kind of thing, which is important to note. But I think it's also an opportunity to flesh out why they don't want the person to know what is actually happening to them. If it is that person's actual decision and they've said to their family, you know, when the time comes, I don't want to know, that's fine. But if it is about that person falling apart because they find out that they're dying, well, they probably have the right to fall apart, even though that's going to be difficult for the family to watch. But that person is the person that is dying. And so they also are then not given that opportunity to do their own processing and grieving for their own life and things that they won't be able to see. So it's quite a difficult area, this one, I think. Yeah.
Thank you. I guess it's again back to the first rule, that communication, and just talking and trying to actually ask some more probing question. What is it that you're concerned? What is that fear and concern comes from? Sometimes we may not be able to actually fix it, but at least it gives us a bit of insight what is upsetting them or upsetting the person most. So according to the Department of Health and Medical Treatment Decision Making Act 2016, all adults have capacity to make decisions unless medically challenged, and a person with decision making capacity has the right to refuse medical treatment. And we should actually obtain informed consent prior to providing routine care. However, you don't need an informed consent to provide palliative care if a patient is unable to give consent. You don't need consent from the patient, and a medical treatment decision maker or the next of kin cannot refuse palliative care. And this one talks about that act. This is about the human rights and palliative care. So as per World Health Organization statement, palliative care is explicitly recognized under the human right to health, and it should be provided through person-centered and integrated health services that pay special attention to the specific needs and preference of the individuals. I guess we have some other challenging codes that people would say you're just starving or dehydrating him to death, or you're killing him with morphine. I guess I might again open to Chien and how do you, Chien, respond to these comments?
Thanks, Hossein. Just in the interest of time, I'll be very brief. And yeah, I really just go straight to the cause and effect and reminding people that it's because they're dying. That's why they don't need or can't tolerate, in fact, the food and fluid, because the hallmark of organ failure is that, which is universal in a dying person, in that if we put more fluids in, they won't stay in the vessels. They'll go to the lungs, they'll go to the legs, they'll cause problems. Similarly, opioids or medications are used when there is pain. So it's not there for hastening death or any other reason. It's their medications are only used if there is distress. And just reminding the family that we don't use them either unless there is pain that we use it for.
I'll be really quick too, because I was just going to say that often I think in these circumstances it's education, because people don't necessarily know that, if they haven't been around when someone has been dying before, they don't necessarily know that physiologically they stop being able to tolerate food and fluids and things like that. And I mean, the morphine thing, I think it's just had a bad rap, and it's a misconception that we need to educate people on. But they are tricky. But yeah, I think it's an education thing most of the time. Yeah.
That's right. Thank you. Just acknowledge we have 10 minutes to 8. So it's the physiological response. Just people actually start having social withdrawals, and food is one of those things that they become less interested. And again, in terms of interest of time, I just go through this as well. That respiratory secretions, or they used to call it death rattle or noisy breathing. It's something that can happen quite in a wide range of patient at the end of life. Some article talk about 23 to 92% of cases. So it's important to actually educate them, as Anna said, and sometimes even beforehand, so that, well, this can sometimes happen. It doesn't mean that they're distressed. This is because the turbulence of air going through the saliva, pulling back of the throat. It doesn't mean that they're choking or drowning in themselves. So education and giving them information is very important. And very briefly about advanced care planning. I love this quote from Dr. Frank Brannan, palliative physician. He said, it's a letter to my future doctor. So it's an advanced care plan, something that for the future, when your doctor or nurse reads that, and you don't have the capacity to tell the nurse, doctor, what you want, that clinician would have some idea, your preferences, your values, what means most to you. And as per Victorian Advanced Care Plan form, it's got 4 major sections, which includes patient's information at the very beginning, and then value directives, instructive directives, and then they can actually fill out a medical treatment decision-making appointment, which we used to call it medical power of attorney or substitute decision maker. They had other names in the past, but it's been all replaced since 2018 to medical treatment decision-making. And just to be aware that the instructional directive section has a legally binding statements directed to the person's health practitioner. So the patients can note things that they want or they don't want to receive. I guess the other topic is about how to respond to hasten death. I'm not sure if you have enough time to go through that, but then again, it's more about finding the motivation for this request. This is usually a combination of relentless physical symptom or progressive debility, or combination of loss of sense of self, or loss of control, or fear of the future, fear of uncertainty, or sometimes fear of being a burden to others, that people want to request to actually hasten death. Is it something, Chien, that you can actually give us a bit of insight in short minute, please?
Yeah, so again, that association between medications, and we have some comments in the chat about syringe drivers, is important to dispel, because of course when there's it's association, then people are afraid to start the medications in a timely fashion, but also expect that death will happen soon, and in thinking that, oh, the person is just lingering and we need to do something about it. And where in fact these medications and interventions are really for the symptoms. Is I usually do routinely, and especially nowadays, routinely go through that an unconscious person actually don't have a sense of time. It's one of the first things to go. And yeah, it may seem long and short to us, but it's not to the person. And we all generally have experience of going to the deep sleep, and when we woke up, lose track of time.
Thank you. And I guess some physicians are frightened by these requests, feeling that they're being asked to cross unexpected professional boundaries at times, and others may be tempted to quickly exceed, and imagining that they would want the same thing to happen to the patients if they were in the patient's shoes. I guess it's important to know that opiates and benzodiazepines are not very reliable lethal agents, but it does actually opens up some conversation. What is the fear behind that question? Why are they actually asking for that? So it's about just clarifying, exploring, evaluating what is actually distressing them, what is actually that they want to end their life, that is upsetting them about. I'd like to just emphasize in here that I wasn't specifically, when talking about the VAD as palliative care Victoria volunteer assisted dying is not part of palliative care practice. And if palliative care health professionals or organizations choose to offer and provide volunteer assisted dying for their patients with life-limiting illness, this is a practice separate from palliative care. But we have been dealing with the quest for hastened death even prior to VAD legislations, and it doesn't necessarily mean that people want to die quickly. It just they have some concerns that it's brewing. So we talked about that quite a lot of topics, and sorry we had to actually rush at the end, but we use a few references that I'd like to actually everyone to see from different resources. And this is about if you would think that your patients or client would benefit from having a community palliative care through Banksia, if they are within that catchment, this is the way to do a referral. People can do self-refer or refer by someone else, or generally by the treating doctors or the clinicians. And but generally, if you feel like you need to refer to community palliative care, this is the way. That palliative care advisory service statewide. That's the number. And there are a number of research, clinical research trials that at Banksia we are involved with from a bigger perspective, with different research studies, and it is growing. The list is growing fast, Chien, isn't it? Is there any questions from the? I might just stop sharing my slides. If there's something that, Chien, you want to address, if there was some questions in the chat box.
No, I think we've addressed all of them. And I think it's Crystal who's going to go through Health Pathway with us.
Thank you, everyone. Just go back to Crystal.
Hi, thank you so much. We're sharing okay there. Good evening, everyone. My name's Crystal Barbedo. I'm the Program Health Specialist at Health Pathways Melbourne. I understand that our time is precious and we're definitely at the end of the night. So in the limited time we have, my goal is to demonstrate how Health Pathways Melbourne can be a fantastic resource, ensuring that you can swiftly access the correct information at the point of care with your patients. Health Pathways Melbourne is a collaborative online resource developed by Eastern Melbourne and Northwestern Melbourne primary healthcare networks in partnership with healthcare professionals and organisations in the Melbourne region. It provides clinicians with a single website to access a comprehensive collection of locally relevant clinical information and guidelines designed to support general practitioners and other healthcare providers in delivering consistent and evidence-based care to their patients. This presentation will demonstrate how to access and navigate Health Pathways Melbourne to find relevant pathways and resources to assist the clinicians with the difficult conversations that need to be had regarding palliative care. Navigating Health Pathways. Simply log on to Health Pathways. Here's a home page. You can see the latest news and pathway updates. Search for the relevant pathway you're looking for by using the table of contents, or you can use the search bar at the top. Today, we're going to look at terminal phase management. Firstly, you can see here is the clinical editor's note, which provides an update information relevant to the point of care. Here, taking us to the PCAM, core medicines, and providing the core medicines list just there. As we go down the page, we get to the assessment section, which is a concise list of steps that users may consider taking to diagnose. Drop boxes throughout provide additional information. And links to different tools as well. As we continue navigating down the page, I stopped there at the goals of care. That was a big one for tonight. Goals of care, and we've also got the medical goals of care, just to ensure that everyone's on the right page in regards to the wishes of the patient. And here, I'm going to take you out to the advanced care plan page. The management section, as we go a little bit further down, again, has drop boxes throughout, providing you additional information on what to expect and what might be needed in the terminal phase. Additional information on particular symptoms that might require management, like terminal delirium. Going all the way down, we're going to the referral section. Here, we have links out to relevant pages. I'm going to take you to the Specialist and Palliative Care Services page. Here, you'll find private and public, which is specific to the Eastern Melbourne and Northwest Melbourne primary healthcare networks. I have criteria that's required to meet. And here under the Eastern Melbourne, you will find Banksia Palliative Care Services right there with all their information and service-specific criteria. Returning to the page. I'm going to take you to advanced care planning. Often GPs at the point of care may find it difficult to actually locate some of these documents. This one has been recently updated by Dr. Precious Maguire. And we cover all of the things from decision maker all the way through to advice and assistance with APC. Returning back to the terminal phase management page. At the bottom of the page, you will find additional information, specific links that have been popped under there for the health professionals and for the patients. This slide just provides a list of relative pathways, resources, and referral pages in the palliative care suite. We actually have over 40 available on Health Pathways Melbourne. And to access Health Pathways, just go to the website address. Otherwise, we've got the QR code there, which you can register at. Alternatively, you can send us an email on info@healthpathwaysmelbourne.org.au. And I'll take the opportunity. We are with HealthPathways doing a amazing virtual reality training for dementia. We have 2 sessions available. So if you're interested, please help yourself to scanning the QR code there to express your interest. And those are running in May. So thank you so much.
Thank you very much, Crystal. So just to round out tonight, I want to thank you all for being part of tonight's presentation. It's been a real pleasure to have you all here. I hope you've taken some really valuable insights and considering the way that we communicate in these difficult times. By participating in tonight's RACGP accredited activity, you'll receive 1 hour of educational activities, which I'll lodge on your behalf. So that we can further improve the education workshops, I really implore you to please provide us some feedback on tonight's session, which you can do by scanning the QR code on the left of the page. At the end of this session, the survey link will also pop up on your screen to provide some feedback. Your responses are really valued, and so if you do have a moment, please fill that out. If you haven't already done so, you can register for the next event, which is the role of the GP in prescribing opioids for palliative care patients, which is being held next Wednesday, same time, same place, so on Zoom at 7 p.m. There'll be a follow-up email that everyone will receive, which will include a copy of the presentation that you've seen tonight, in addition to any relevant resources. That will also include a survey link in that email too. You will also receive your certificates within the next 4 weeks of this session from EMPHN. We thank you for your time tonight and attention, and from all of us, we hope you have a lovely evening. Bye for now.
Thanks, everyone.